All right. Hey, it is 10 a.m. How are you guys doing today? All right. So today we are talking about the respiratory system. All right. And so the respiratory system, it consists of passages that filter the incoming air and then transport it into the body, into the lungs, into the many microscopic air sacs called alveoli, where gases are going to be exchanged with the blood. So, respiration is the process of exchanging gases between the atmosphere and the cells of the body. All right, so there are five events in respiration. First is ventilation, which is the process of bringing air into and out of the lungs. Um, there is external respiration, which is the process of um, transporting gases between the wall of the alveolus into the blood and from the blood into the alveolus, and then transporting those gases from the lungs to the body's cells. Then we have internal respiration, where we transport that gas from the blood capillaries into the tissues, and then from the tissue interstitial fluid into the cells. Okay, those are the five steps: bringing it into the body, bringing it into the blood, transporting it through the blood to the tissues. All right, from the blood into the tissues, and then from the tissues into the cells. All right, so it occurs on a macroscopic level as a function of the lungs. So we exchange carbon dioxide and oxygen mainly. So there are other gases in atmospheric air. In fact, atmospheric air is about 70% nitrogen, and some nitrogen will be, actually a fair bit of nitrogen will be exchanged between the blood and the oxygen. I'm sorry, the lungs. However, we don't use the nitrogen, so we don't talk about it very often. It's there, but we don't use it, so we don't talk about it. We talk mainly about oxygen and carbon dioxide. Now, oxygen is at a relatively high concentration outside the body. That's 21%, 21% roughly of atmospheric air is oxygen. A very small percentage, less than 1% of atmospheric air, is carbon dioxide. And so, one of the interesting things we'll see is that oxygen, the source for this is outside the body, atmospheric air. The source for carbon dioxide is inside the body. Of course, that's the result of aerobic metabolism in our cells and in our tissues. All right, we are going to be producing carbon dioxide, and so we are going to be exchanging it with the air in the lungs so that we can get the carbon dioxide out of the body. All right, so gas exchange, it occurs at both the cellular and molecular levels. We exchange it with, for instance, hemoglobin. And anyway, so the aerobic reactions of cellular respiration use oxygen to accomplish ATP production. We need oxygen in the mitochondria to perform something called oxidative phosphorylation. That's a big fancy word, meaning we use oxygen to add phosphate groups to ADP to turn it into ATP. Okay, and then we can use ATP to power all of the enzymes that do the cellular work. All right. And so, as a end product of cellular respiration, we produce CO2. All right, and that you can call that a metabolic waste. It's a product of metabolism that is a waste product. We can't use CO2. I mean, well, so it does serve a purpose in the blood, but we will need to get rid of it, and too much of it will become toxic. Too much CO2 will acidify the blood. All right. Now, in the blood, you can combine CO2 and H2O to form H2CO3, which is carbonic acid. Now, if carbonic acid loses one of these hydrogens and becomes HCO3, then it is a molecule known as bicarbonate. Here, the slide says that carbonic acid helps maintain blood pH. Actually, bicarbonate helps maintain blood pH. We are going to try to eliminate the hydrogen ion, which fell off of carbonic acid. And then what we're left with is bicarbonate, which is a base. And now bicarbonate serves as a buffer because it can absorb loose hydrogen ions in the blood, and that helps maintain blood pH. All right. The respiratory system provides oxygen for the aerobic reactions and also helps eliminate CO2 from the blood. Now, we say eliminate CO2 at the appropriate rate because if we eliminated all of our CO2, we wouldn't be able to produce bicarbonate. Bicarbonate is an important buffer in the blood, and so we need some CO2, but too much will acidify the blood by creating too much carbonic acid, too many loose hydrogen ions. So the respiratory system can be divided into two tracts. You've got an upper respiratory tract, which includes the nose, nasal cavity, the paranasal sinuses, uh, and then you've got the pharynx. Remember, the pharynx is a common passageway for the nose and the mouth. Okay, so this region back here. And then you have the lower respiratory tract, which includes the larynx, okay, kind of the opening into the respiratory tract here. And then the trachea, a lot of people call it the windpipe. So this is the trachea here. And then you have the bronchial tree. Here is the primary bronchi, okay, the first divisions off of the trachea. And then you've got the secondary and the tertiary bronchi. And then we divide further and further down into smaller bronchi and bronchioles. Okay, and then ultimately down to the alveoli, the air sacs of the lungs. All right, so the bronchial tree is basically a series of tubes that get smaller and smaller and conduct air down to the air sacs of the lungs. Here is, by the way, the right lung and the left lung, and something you may notice is that the right lung is a little bit larger, and it also has 1, 2, 3 lobes, whereas the left lung only has 1, 2 lobes. Okay. You also may notice this indentation over here. Okay, of course the heart sits between the lungs, but it sits a little bit more on the left side, and so it invades the space of the left lung just a little bit here. All right, so the nose, here we have nostrils, also known as the external nares, which provide openings for air into the nasal cavity. All right, the nasal cavity, the lining of it, is protected by internal hairs. Okay. In the nasal cavity itself, we have these 3 bony shelves, known as the superior, middle, and inferior nasal conchae. And you may remember these from the skeletal unit. If you don't, that's okay. These 3 ridges are also known as the turbinates. Okay, so the root word of turbinate is turbine. Remember that. So as we inhale air through the nose, the turbinates are going to spin it. All right, they're going to swirl that air around the nasal cavity. Now, why would we do that? Well, the nasal cavity is lined with mucous membranes, which are moist, and the air is going to pick up moisture from the mucous membranes as it gets swirled around. It's also going to get warmed up as it gets swirled around, and then we finally inhale that warm, moist air from the nasal cavity. Well, down here, sorry. And the reason for that is that we're better able to absorb oxygen from warm, moist air than we are from cold, dry air. You may notice on one of these particularly cold days, if you're out walking the dog and you get hit with a burst of cold air, your respiratory passages, your throat, and such may instinctively close up, and it'll become difficult to breathe. And the reason for that is um, that cold air can be damaging to the lungs. All right, so the nasal cavity, we talked a little bit about this already. It's divided into left and right portions by the nasal septum. Remember that word septum means to separate, and so that'll always be a wall between things. Here, nasal septum is the wall between the left and right portions of the nasal cavity. All right, so the conchae, they separate the nasal cavity into passageways called meatuses. The upper portion of the nasal cavity contains olfactory receptors. You probably remember that from the nervous system unit. And yeah, so the olfactory receptors are embedded in the superior portion of the nasal cavity, which allowing us to smell. Mentioned it's lined with mucous membrane. That's the pseudostratified ciliated epithelium, and you have the goblet cells there producing the mucus and the moisture. So the nasal cavity conducts air, of course, but also, as we mentioned, warms and moistens, and then also filters the air. Here you can see that pseudostratified ciliated columnar epithelium. You can see the mucus cells here, the goblet cells producing the mucus. Okay, here you can see particles trapped in the mucus, and then those cilia, they'll beat to move the mucus along. And when they move the mucus, that carries the trapped particles along as well. In the nasal cavity, the cilia will be beating posteriorly, moving the mucus back into the pharynx and then into the esophagus, where we can swallow the mucus and recycle it in the stomach. All right, so the paranasal sinuses we talked about in the skeletal unit. These are air-filled spaces found in the maxillary, frontal, ethmoid, and sphenoid bones of the skull. The openings to the sinuses are in the nasal cavity. When you get a, excuse me, when you get a sinus headache, sinus pressure headache, the mucous membrane lining these sinuses has become inflamed and swollen and puts pressure inside these spaces in the skull. The sinuses also reduce the weight of the skull, and they can serve as resonance chambers for the voice, which is one reason why your voice sounds different to you than it does to other people. All right, so the effects of cigarette smoke on the respiratory system. I think we mentioned this a couple times probably in my A&P1 class, but basically when you smoke, that's going to paralyze or kill the cilia in the pseudostratified epithelium found in the nasal cavity and in the trachea. Okay, and so when you do that, dirt and pathogens and other things, they get lodged in the mucus, but then you can't move them up, right? Those cilia aren't beating anymore, they aren't moving the mucus up. And so you get what's called the smoker's cough. Everybody's heard it, everybody's seen the smoker's cough. And that results when, again, the cilia are paralyzed. And how are you going to get that mucus up? You're just going to have to manually cough it up. Okay. So pathogens, because they're not being effectively removed from the mucus, they can now access respiratory surfaces, so you're more prone to infections. And then coughing leads to chronic bronchitis, which is inflammation of the bronchi. Then you can see bronchial thickening, which results in difficulty with expiration. That's forcing air out of the lungs. Alveolar walls will be destroyed, leading to a condition called emphysema, where again the walls of the alveoli kind of break down and the alveoli fuse. And then you'll see abnormal cells dividing and get replaced by ciliated cells. This is one of the markers for kind of, it's one of the steps toward developing cancer. Lung cancer develops in 20% of smokers. And then secondhand smoke or environmental tobacco smoke can also endanger non-smokers. All right, just 1 second. Need to take a break. Sorry, I needed a smoke break after all that. Just kidding. Okay, back to this. Where's my mouse? There it is. Okay. So the pharynx, we mentioned earlier, is a common passageway for food and air. Air through the nose, food through the mouth, and then also air through the mouth. It may be better phrased as a common passageway for the nose and the mouth. All right, and so air and food both pass through the pharynx on their way to either the esophagus or the larynx and trachea. And it's divided into three portions, and the names will tell you exactly where we're talking about. We got the nasopharynx, which is this region behind the nasal cavity. Then you got the oropharynx, which is this region behind the mouth, behind the oral cavity, I should say. And then you have the laryngopharynx down here, which is the passageway leading to either the esophagus or the larynx. Okay, it's this region behind the larynx. So the larynx is an enlargement in the airway just above the trachea. So you can see the thyroid cartilage here, hyoid bone up here, epiglottic cartilage behind. This is a posterior view here. So the larynx houses the vocal cords, and it's composed of a framework of muscle and cartilages that are bound by elastic tissue. The thyroid cartilage is the largest of the uh, laryngeal cartilages. Then the cricoid cartilage, just inferior to that, is the second largest. All right. And then the epiglottic, okay, is this flap up here. The epiglottic cartilage forms part of the epiglottis, which is a sort of flap that covers over the trachea. I'm sorry, covers over the larynx and prevents food from moving in. And so here you can see the epiglottis, this kind of flap up here. Right here would be the thyroid cartilage right here, and the cricoid down below. Thyroid here. Epiglottic cartilage forming the epiglottis up here. And when we swallow, it looks like you would lower the larynx. I'm sorry, no, it looks like you would lower the epiglottis to cover this. Actually, what you do is you raise the larynx up to meet the epiglottis. Okay, so you'll actually raise the larynx up to meet the epiglottis and close off this space. That way, when you swallow, food passes down the back into the esophagus. Water, too, ideally. Occasionally, that doesn't happen, and food and water enter into the larynx, and we've got to cough repeatedly to try and clear it all out, because you definitely do not want food or water entering the lungs. All right, good. So we talked about that. So you've got false vocal cords, and then you've got true vocal cords. Okay. So the false vocal cords are superior to the true vocal cords, but they don't actually produce any sound. The true vocal cords are the lower folds seen here, okay, and here, okay, and they will produce sounds, okay. Now the space between the vocal cords is known as the glottis. All right, the epiglottis is above the glottis, okay, this space in here. All right, the trachea, which many people will call the windpipe, all right, is this region here. Now it's surrounded by a bunch of C-shaped rings. And I want you to go ahead and make the letter C with your hand. Doesn't matter if it's backwards or forwards, the letter C. All right, there are all these C-shaped rings, all right, traveling down the front or the anterior surface of the trachea. And let's go ahead and understand the purpose of these C-shaped rings. So in the space between your fingertips, between your thumb and your fingertips, okay, there's going to be smooth muscle there completing the ring. The rest of it, where your hand is, that is cartilage. Okay, so why do we have C-shaped rings and not O-shaped rings of cartilage in the trachea? The interesting thing about it is immediately posterior to the trachea is going to be the esophagus. And so wherever your fingertips are, there's smooth muscle there completing the ring around the trachea. And then just beyond that is the esophagus. And the esophagus is lined with smooth muscle, smooth muscle and epithelium. And most of the time it's flat because we're not swallowing most of the time. But when we do swallow, it expands very quickly to accommodate sometimes very large mouthfuls of food. If you're really pigging out on some pizza and you just swallow this giant ball of pizza, the esophagus is going to have to expand very quickly. And so by having this C-shaped ring on the trachea, the esophagus is able to expand without damaging the cartilaginous ring surrounding the trachea. If we had an O-shaped ring, the esophagus would either not be able to expand enough, or it would expand and it would damage the cartilaginous ring. All right, so the C-shaped rings are very interesting. What else about them? Just an interesting counterpoint, the C-shaped rings hold the trachea open all the time. Why? Because we are always breathing. We always need to exchange gases 24 hours, excuse me, 24 hours a day with our environment. Okay. Let me check the volume over here. Can you guys hear me? Test. Yep, okay. Sorry, I was worried you guys couldn't hear me. All right. Good. So, as we were saying about the trachea, when it enters the thoracic cavity, it splits into right and left primary bronchi. Okay? The first divisions are the right and left primary bronchi. Then, after that, we will divide into secondary bronchi. Okay, secondary bronchi, and then finally into tertiary bronchi. All right. And then we'll make further divisions as we approach the alveoli. The trachea, we should mention again, is lined with ciliated pseudostratified columnar epithelium, just like in the nasal cavity, except here the cilia are beating to push the mucus up. Going back, we'll push the mucus up into the laryngopharynx, and then we'll push the mucus over to the esophagus so it can be swallowed and recycled. unless you are a smoker, in which case your cilia are paralyzed and then you're going to have to manually cough it up. All right. So here you can see kind of a cross section of the trachea. We've got that C-shaped ring here. In the back is that smooth muscle, and then of course the esophagus would be right back here. Okay. Lining it is the ciliated epithelium here. Okay. You can see the ciliated epithelium lining it there as well. So a tracheostomy is a procedure, you can see it here, that cuts an opening in the trachea so that you can insert a tube for air exchange. This is done if an object is lodged in the larynx or the trachea. So if you had food lodged up here in the larynx, okay, we could make an incision in the trachea down here and we could still exchange gas between the atmosphere and the lungs, kind of bypassing that. All right, so the bronchial tree consists of airways that lead from the trachea down to the alveoli of the lungs, the quote unquote microscopic air sacs of the lungs. And you can see that again here. We're leading down further divisions until we reach the respiratory bronchiole, the alveolar duct, the duct leading to the alveolus, and then the alveoli. I'm sorry, let me back up a second. This is an alveolar sac, which is made up of alveoli. Okay, so let's follow this duct down. Okay, and so the air enters a central space, and then from there is able to enter all of these individual sacs. Okay, each one of them exchanges gases with the blood. So the bronchial tree again here we see the trachea, the primary bronchi, secondary bronchi, and then it can be a little tough to see beyond that. But then we've got the intralobular bronchioles, which are these kind of thin ones passing through the center here, and then branching off of them are the terminal bronchioles, and you might be able to see some tiny respiratory bronchioles, although they really should be microscopic. Over on this side, we have the intralobular bronchiole branching out down into the terminal bronchioles, and then finally the respiratory bronchioles off of the terminal bronchioles. And the terminal bronchioles lead to alveolar ducts, and then the ducts lead to alveolar sacs. This is an alveolar sac made up of multiple alveoli. By the way, singular, one of them is an alveolus. Alveoli is plural. All right. So all the structures of the bronchial tree down to the terminal bronchioles are part of the conduction pathway. That means they transport air, but they don't participate in gas exchange. All right. So everything down to the terminal bronchiole seen here, okay, and here, they're not going to exchange gas with the atmosphere. It will not occur there. You can tell it's surrounded by a lot of smooth muscle, and if you're surrounded by smooth muscle, then you're not going to be very effective at allowing gases to diffuse out of your tissue and into the bloodstream. All right. Now, the respiratory bronchioles can participate in gas exchange, as can the alveolar duct. All right, but the vast majority of it occurs in the alveoli. And so if you take a look here, you can see the blood, okay? And there are vessels serving the terminal, passing by the terminal, not the terminal, sorry, the respiratory bronchioles and the alveolar ducts. And so there you will be able to exchange a little bit with the blood. But look at the blood supply around the alveolus or the alveolar sac, okay? Much richer, much denser, lots of capillaries here. And that's where we're going to be most effective at exchanging gas. between the atmosphere and the blood is wherever the concentration of blood capillaries is highest, and that happens to be around the alveoli. So the structures, by the way, which which start up after the terminal bronchioles, we've got the respiratory bronchioles, the alveoli, the alveolar ducts. They're part of the respiratory pathway since they contain alveoli and can perform gas exchange. All right. So for the respiratory tubes, um, the main bronchi, their structure is going to be similar to the trachea, but they have cartilaginous plates surrounding them instead of the C-shaped rings. The bronchi, they continue to branch, they become narrower and narrower, and then the amount of cartilage is going to decrease and then eventually be replaced with smooth muscle. The cartilage disappears in the bronchioles, smooth muscle becomes more prominent, then even it begins to diminish, as we saw when you approach the respiratory bronchioles and the alveolar ducts. The respiratory tubes become thinner and thinner, and the type of epithelium there changes. So we see pseudostratified columnar epithelium in the larger tubes, such as the trachea and the bronchi. Then we see simple cuboidal epithelium in the respiratory bronchioles. All right, and then we see a simple squamous epithelium in the alveoli. In the alveoli, again, that's where we're exchanging gases, and so simple squamous epithelium, it's very thin. It's one cell layer thick. The cells aren't very tall, and so we're able to transport gases across that type of cell very quickly. All right, so here you can see the alveolus itself made up of simple squamous epithelium. Now the capillary, hold on, excuse me. So the capillary also is made up of simple squamous epithelium. All right, and so what you have here, the only barrier between these two is you've got the wall of the alveolus made up of simple squamous epithelium. You have the wall of the capillary, also made up of simple squamous epithelium. And then between that, you have two basement membranes, and that's all that separates the air in the alveolus from the blood. Okay, that may sound like a lot, but as far as barriers to the outside of the body go, this is really thin. These four layers also happen to be really permissive to the movement of gases. And so oxygen and CO2, you probably remember, they're able to diffuse through plasma membranes easily. They can just pass through as they need to. All right. Also remember, atmospheric air is rich in oxygen and poor in CO2. Blood, as we approach the lungs, is going to be poor in poor in oxygen and rich in CO2. And so these gases are going to go wherever their concentration is lowest. The concentration of CO2 in the lung air, which came from outside the body, the concentration of CO2 there is going to be low, and so CO2 is going to move from the blood into the lung. Concentration of oxygen in the alveolar air, which came from outside the body, is going to be high, and so oxygen will move from the alveolus down into the blood where it is lower. All right, so here you can see an electron micrograph of a bronchiole, just an air passageway here, kind of cool to look at. Over here, you can see kind of the alveoli. Really what we're looking at are the capillaries. We're looking at the blood. In here you would see an alveolus, but we're looking at the blood capillaries. And you can see this rich network of blood capillaries surrounding the alveoli. All right, so the lungs are soft, spongy, cone-shaped organs in the thoracic cavity. They're separated from each other by the heart and the mediastinum, which is that cavity that encloses the heart and the thymus. All right, now the right lung has three lobes, as we mentioned, and the left has two. All right, and then of course it's all surrounded by the thoracic cage. So the hilum is a region on the medial surface of each lung where the bronchus and large blood vessels enter the lung. Okay, and so a hilum, and we'll see this term again in the kidneys, is basically the entry site for the large blood vessels, and in the case of the lungs, also the bronchi. All right, the visceral pleura is the inner layer of the serous membrane. Okay, and there are two visceral pleuras, two pleural membranes. The visceral, there's a right and a left basically, one for each lung. And then the parietal pleura is the outer layer of the serous membrane. There's two of them again, one for each lung, and it lines the thoracic cavity. The pleural cavity is a potential space found between the visceral and the parietal pleura. So let's look here. We've got the right lung here and the left lung here. You can see that visceral pleura surrounding the lung, all right? And then lining the thoracic cavity is the parietal pleura, okay? And then the pleural cavity, is this space between them, this potential space. And it's a potential space because it's going to be mostly empty or maybe filled with fluid, serous fluid, but it's under physiologic conditions, it's collapsed. I say under physiologic conditions. There are conditions where you can see an increase of fluid in this space, and that's going to increase pressure on the lungs, and that's going to be problematic. That would be a pathologic condition as opposed to physiologic, normal conditions. So here are all the parts of the respiratory system. We covered them pretty well, I think. All right, sorry, I think I scrolled a few too many. All right, so here's some things that irritate the lungs. We've got asbestos. We've all heard of it. It's fire retardant mineral, actually. I thought it was man-made, but it turns out it is mined from the ground. Anyway, it's a naturally occurring mineral, formerly used in buildings because it resists burning, but airborne fibers can lead to scarring of the lungs and shortness of breath, as well as lung cancer and mesothelioma, which is a cancer actually of the pleural membrane. Then we have berylliosis, where beryllium, it's found in industrial applications, and in some people, exposure to beryllium dust or vapor can evoke an immune response that scars the lungs and impairs breathing. Then you have extrinsic allergic alveolitis. All right, so this is an allergic inflammation of the alveoli from outside the body. Results in long-term exposure to dust of an organic origin, so like skin and pet dander, that kind of thing. The acute form causes fever and breathing impairment, and then the chronic form changes the lungs over time. And then with air pollution, you have microfine, that's tiny airborne pollutants that can pass through the protective mechanisms, past the mucous membranes, and reach the alveoli. It can worsen asthma, irritate eyes and lungs, and increase the risk of heart disease and lung cancer. And that's one of the reasons that asthma is so prevalent and so extreme in the region where we live, and that's because we live in the Ohio River Valley, which is a geographic depression. Air tends to stagnate here, so the pollution we create does as well. All right, so breathing mechanisms. Let's see, do we want to get into this? today? We've been going about 40 minutes. Yeah, let's cover the basics of this before we close up for today. All right, so breathing, also known as ventilation, is the movement of air from outside of the body into the bronchial tree and the alveoli. So the actions responsible for these movements are called inspiration, also known as inhalation, and expiration, also known as exhalation. One inspiration and then the following expiration is a respiratory cycle. So one breath in, one breath out, that is a respiratory cycle. So the atmospheric pressure is the force that moves air into the lungs. At sea level, atmospheric pressure is 760 millimeters of mercury. Now you're going to see this unit a lot, mmHg. Hg is the atomic symbol for mercury, mm is millimeters. And so what is or are millimeters of mercury? The short answer is it's just a unit of pressure. Okay. The same way an inch is a unit of distance and a pound is a unit of weight. It would probably best just to go ahead and memorize that millimeters mercury is a unit of pressure because we're going to see that. We're going to see that quite a lot, I think. All right. So actually, now that I'm saying that, I think we talked about this in the cardiovascular unit. We would have to have talked about blood pressure. Uh, now what are they literally? Well, this is the amount of pressure needed to move mercury 1 millimeter up, uh, up a glass tube. All right, and so in this case, the pressure of the air in the atmosphere at sea level is enough to move 760 millimeters of mercury up a tube. All right. So don't worry about that. Millimeters mercury is just a unit. mmHg just a unit. And then it is important to remember that the pressure in the atmosphere at sea level is 760 millimeters mercury. Now, as you go up in elevation, the air pressure will actually drop, and most places in the U.S. that's not significant. It is a little significant in, say, Denver, the mile-high city, right? If you were to climb Mount McKinley in Alaska, the air, actually, they just renamed that, didn't they? I don't know what the new name is. But if you were to climb Mount McKinley in Alaska, uh, the air pressure would be low. And of course, if you were to climb Mount Everest in the Himalayas, the air pressure would be much, much lower than at sea level. All right. But for the most part, most people live at or around sea level, and so air pressure will be 760 millimeters mercury for almost everyone, almost all of the time. All right. Good. So when the respiratory muscles are at rest, the atmospheric pressure and the alveolar pressure are equal. Okay. The pressure inside the lungs, in the alveoli, and the pressure outside the body are equal when the respiratory muscles are at rest. And if the two pressures are equal, there's not going to be any movement of air into the body or out of the body. Now, this picture over here demonstrates an very important principle, which is that for volume and pressure are inversely related. Okay, and again, this is a really important concept. Um, Here, all right, on the left compared to the right, we have lowered the plunger, which has increased the volume in the syringe, which has decreased the pressure. Now that we've decreased the pressure, air is going to move into the syringe. Or if you had the tip in some fluid, fluid would move into the syringe. Now over on the right, we've raised the plunger, we've decreased the volume, which increases the pressure. Decreased volume leads to increased pressure. And when we increase the pressure, the air or the fluid in the syringe will move to wherever the pressure is lower, outside the syringe. Okay? So really important concept there. Pressure and volume are inversely related. When one goes up, the other goes down, right? When one goes down, the other goes up. Mainly when volume goes up, pressure goes down, and when volume goes down, pressure goes up. Really should phrase it that way because it's the change in volume that's leading the change in pressure. All right, so this is Boyle's law. We just stated they are inversely related. So if the pressure in the lungs and the alveoli, or the intraalveolar pressure, decreases, then atmospheric air moves into the airways. In other words, if the pressure in the lungs and in the alveoli decreases, air is going to go wherever pressure is lower. In this case, that's in the lungs. And so atmospheric air moves in through the respiratory passageways into the lungs until the pressures equilibrate, until the pressure is the same in the lungs as it is outside the body. When that happens, air is not going to move anywhere, right? Now, on the other hand, if pressure in the lungs is higher, okay, if pressure in the lungs is higher, then we are going to see air move up out of the respiratory passageways and then outside of the body. All right, if pressure, in other words, is lower outside the body than it is in the lungs, then air is going to move from the high pressure in the lungs to the low pressure area outside the body. Okay, and so pressure changes in the thorax and in the lungs and alveoli are going to drive the movement of air, and it's going to go wherever the pressure is lower. All right. So we don't need a large change in pressure. In fact, when we inspire, we're going to drop the diaphragm. And by dropping the diaphragm, well, it contracts and drops. And when it drops, it increases the volume of the thoracic cavity, which increases the volume of the lungs, which is going to decrease the pressure in the lungs. And it's going to typically decrease from 760 millimeters mercury to about 758. It's not a big change, but it's enough. All right, and so when we drop that pressure to 758 millimeters mercury in the lungs, air will move from the higher pressure area outside the body into the lungs until the pressure reaches 760 millimeters mercury, until it's equal inside and outside the body. All right, now the short of it is when we're done inhaling, we're going to allow the diaphragm to relax, to move back up, okay, and that's going to decrease the volume of the lungs. And when we decrease the volume of the thorax and of the lungs and the alveoli, we're going to increase the pressure. And now the pressure is going to be higher inside the lungs than it is outside the body, and the air will move up and out to the lower pressure area outside the body. All right, so that was kind of an oversimplification. The diaphragm is the main respiratory muscle, but there are others such as the intercostals, the pectoralis minor, etc. We'll talk about those when we get to them, I think in a couple more slides. So during normal quiet inspiration, the diaphragm and the external intercostal muscles, they enlarge the size of the thoracic cavity. When we're just breathing passively, sitting comfortably on the couch, quietly breathing, these are the two muscles acting, the external intercostals and the diaphragm. Lung expansion is aided by surface tension in the pleural cavity. And so basically the serous fluid in the pleural cavity pulls on the visceral membrane, which pulls on the lungs and helps them expand as we expand the rib cage and the thorax. All right. There's surfactant in the fluid in the alveoli, and that's going to reduce the surface tension, which also allows the alveoli themselves to expand. All right, should probably take a step back there. There is a certain amount of fluid in the alveoli. A certain amount of fluid helps with gas exchange and you got to kind of balance two forces there. You've got surfactant, and then you've got the water adhesion principle. And so the water helps collapse the alveoli when it's time to expire or breathe out. And the surfactant kind of fights that force and allows us to expand the alveoli. Without surfactant, we really wouldn't be able to expand them, they would stay collapsed. Good. So a deep or forced maximal inspiration, which is where we breathe in like, okay, that requires the contraction of several other muscles to enlarge the thoracic cavity even more. This includes the pectoralis minor, all right, and the sternocleidomastoid, as well as the scalenes. These all, when they contract, pull on the rib cage and then they lift it and pull it out. Okay, they lift it and pull it out. And by contracting these muscles, we can further increase the volume of the lungs. Now, during normal, quiet inspiration, just passive breathing, it's just going to be the diaphragm and the external intercostals. All right. Now, for the most part, the diaphragm is the most important muscle by far. The majority of respiration is driven by the diaphragm. The external intercostals help during normal inspiration. And then if we really need to force air into the lungs, we can also contract the pectoralis minor, the scalenes, the sternocleidomastoid to expand the rib cage further. But diaphragm always going to be the most important. All right, so moving on. We got these two forces we mentioned. So you've got the elastic recoil, which is where the lung tissues and the abdominal organs return to their original shape after inspiration. So we contracted muscles to move the diaphragm down and then pull the rib cage up and out. And elastic recoil is where we're going to see these tissues go back to their original shape, as well as the lungs go back to their original shape. We also have surface tension in the alveoli created by the thin layer of water in the alveoli we mentioned. Water molecules are attracted to one another, okay, and so they're naturally going to want to kind of pull on each other, which causes the alveoli to collapse. The opposite of this surface tension is the surfactant, or rather, the opposite of this surface tension phenomenon is the surfactant. The surfactant reduces surface tension and allows us to expand the alveoli. Um, then the adhesion of the water molecules to one another leads to surface tension, which helps us collapse the alveoli when we are expiring. I hope that was clear. It's a little tricky. So each of these factors will increase the intraalveolar pressure about 1 millimeter mercury above atmospheric pressure, which forces air out of the lungs. So during normal quiet expiration, this is a passive process, meaning we don't contract any muscles. The diaphragm and the external intercostal muscles just relax and go back to their starting position. That's going to decrease the volume in the thoracic cavity, and that's going to increase the pressure and allow air to leave the lungs. But during forced expiration, like this, where you try and force all the air out of your lungs, um, it's due to the contraction of the internal intercostal muscles and the abdominal muscles. All right, so the internal intercostal muscles, okay, they're going to contract, and then your abdominal muscles as well. I encourage you to go ahead and try both of those, maximal inspiration and maximal expiration, and you will feel, you'll look silly, but you'll feel a little bit of what we're talking about. Okay, so now I think we're good. I think we'll start with this chart when we come back. I'm going to pause for a minute. Do we have any questions? Okay, well, I guess no questions. We'll go ahead and close it up. If you do have any questions, feel free to email me anytime, and I will get back to you within 48 hours. I'm generally pretty good about getting back to you within a day, but 48 hours is the deadline. All right. And great. So look forward to hearing from you.